There we go. Good afternoon and welcome to today's webinar. My name is Terry Belcourt. I'm a registered nurse and a staff person at the SRNA. I'm in charge of the member linkages area, and my role for today is to help facilitate this discussion and to introduce you to Rosalind Compton, who's going to talk with us about caring with older adults. I really like that language, and so I'm excited to hear a little bit more about it as Rosalind talks. This is part of our Emerging Trends in Healthcare series, and something that is timely and really of interest to a lot of people is the differences of working with older adults. So just a couple of notes before we get started. We are going to record this webinar and post the recording for others to take a look at who might not have been able to join us in person. As attendees, you're going to be able to communicate the best with us by putting your questions into either the chat box or into the question and answer area. I'll be monitoring those areas and bringing any questions or comments forward to Rosalind as we go forward. Many of you have already found that chat box, so thank you. If you see a little orange button blinking, that's because I put in a message there for you. It helps you kind of find that chat box. So we do have several people online. We've got an acute care nurse. We've got, let's see, somebody from a surgical ward. So lots of different areas of practice here. So I'm going to just turn this over now to Rosalind and look forward to your questions and comments.
Thank you very much, Terry. Well, it's wonderful to meet you all here in this interesting space. Terry invited me to do this webinar today, and I must admit I didn't know the series existed, so it was a good opportunity to have a whole conversation about what is it and how are we communicating as nurses across the province. And this new exciting way, I think, is great to be able to meet in a place and to have a conversation. I'm kind of hoping that we'll be able to answer some questions, to explore some options, and really begin to look at what does it mean to care with older adults rather to do to or for them. And often that's the language that we use in our nursing practice, is that we develop a care plan for the older adult. We do to the older adult. We're not actually working alongside, living alongside the older adult and understanding the world from their perspective. So in lots of ways, that's where the title comes from, is trying to think differently. So instead of seeing an older adult as just an aged person or someone experiencing decline, we're starting to think about older adults as being people that can contribute to their care, no matter whether they're living with dementia or that they have advanced Parkinson's disease. They're not a disease first. Inside there is a person, and the person really matters. And how do we connect with that person that seems to get forgotten in the system? As soon as cognitively we are unable to communicate or engage, for some reason the healthcare system and practitioners seem to think that we don't have an opinion anymore that matters, and that we don't get asked to join our care routines. We get care done to us. It's our birthday, we get given a bath. It's not a negotiation process. And we don't really have that sense that we're involved in the care. So that's the background of the title, and really trying to push you to think about care in a different way. I guess the main focus for today is starting to think about what does it mean to work with older adults, and remembering working with, living alongside. We're in a partnership here, so definitely patient-focused care, patient engagement, and how do we encourage that in a population that is most often, I would guess, we tend to leave them and ignore them a little bit more than we should, or that we find that they're the least priority in the healthcare system for the dollar expenditure. And when it comes down to registered nurses and the type of work that registered nurses do, what does it mean, and where are we working, and what are our priorities, and why aren't we working in long-term care in a number that For me, I would think long-term care registered nurses is where we need to work. The people living there are very complex. They have very complex healthcare needs, and the clientele and the residents is shifting over the last several years to being way more dependent than they used to be, and often looking at, rather than seeing them as dependent, seeing them as interdependent. We help each other, we give to them, but they also give back to us in their wisdom, their knowledge, their skills, their understanding of who they are. So this exchange and backwards and forwards of interdependency, rather than seeing them as dependent older adults who really, and we use the phrase often, you know, they just come to the long-term care to die. There's nothing more to do for them. We don't need to encourage socialization or engagement, and nurses, registered nurses, don't belong in long-term care. So when we try and think and imagine about changing practice and changing healthcare outcomes, how do we encourage registered nurses to come back into long-term care or back into working with older adults in a valuable relationship, in a valuable, meaningful way for both the nurse and the for the older adult? I guess it's a big question in healthcare, because often behind that comes the dollar. So it's cheaper to employ licensed practical nurses and special care aides to meet the older adults' needs, with the perspective that nursing home clients are not necessarily complex and they really don't have a lot of healthcare needs, to the point of we need registered nurses, nurse practitioners leading the long-term care healthcare team and making sure that the life of the residents is of good quality and that they're getting their needs met, particularly in relation to their healthcare, and starting to really examine what does that look like. As an educator at the University of Saskatchewan, in the nursing program, I've taught nursing for 10 years now. Just a year here at the university, and the previous years, 10 years at Sask Polytech. And what we see among faculty, among students, and among practicing nurses is that you don't need to look after older adults. It's not the role of a registered nurse. Long-term care is the end of your career. You don't want to start your career in long-term care. When you work in long-term care, you're going to lose your skills and lose your abilities, and you really aren't going to be working as a registered nurse. My concern is, how do we change that perspective? How do we get people to see long-term care work matters? It matters that older adults are cared for by professionals who are highly skilled in the care of with older adults. They've got special skills, special knowledge that's related to gerontology and the care of not just the resident, but also the care of the family, whoever that family might be identified by the resident. It could be their neighbor, it could be their community, it could be their children that are scattered all over the globe. How do we connect and build relationships so that the experience of the person living in long-term care is optimal? It's not just about the quantity of life, it's about the quality of life. And to do that, registered nurses need to be in that driving seat, that coordinator of care. We used to call it case management. We're kind of trying to shift that language, because that is not inclusive of the patient when we see it as being managed by the healthcare provider. If we can move towards more of a coordinator of care, it gives that opportunity for negotiation, conversations, relationships, working one-on-one with the person and also with their family and whoever else they identify as being important. So how do we change? Firstly, is that language. How do we get registered nurses to see long-term care as being a place of employment opportunity? So what we started to look at is to build preceptorships, very specific preceptorships for fourth year at the moment, registered nursing students. We are actually going to start to explore the opportunities of what we call an intra-professional preceptorship experience, where we would look at registered nursing, psychiatric nursing, licensed practical nurses, and special care aides with a nurse practitioner, taking a placement all together in a long-term care environment, so that we can start to see this building together of a team, sharing a knowledge, and looking at who's who is responsible for what, to make sure all the needs of the patient are met, not just their basic ADLs, which I think we do quite well. Everyone's very versed at that, but the rest of their life is really put on hold, or it's not significant. So how do we make that attractive to students? Which is where we're kind of looking at registered nurses with a special interest in long-term care or caring with older adults. These nurses are out there. I have met many, many nurses working in the areas of long-term care and with older adults who are excellent preceptors. How do I find those preceptors? And how do they contact me? And then we can meet and really start to explore what are the opportunities for building a good preceptorship experience that lets the student leave the environment either thinking, I will practice long-term care, or thinking older adults require special knowledge and I want to get special knowledge and to be more effective in my role, or I really appreciate now what it means to care with older adults and I'll carry that into my nursing practice no matter where I work. It doesn't matter. I might work acute care, I might work rural, I might work remote, but I will take this very important knowledge and I'll put it into my practice. And they're the type of students that we want to match with a very good preceptor in a nursing home, long-term care home, or a residential facility that also has a very good value of the person as an older adult. So that when you put the three teams, I would say the preceptor, put it with the student, and put it in a home setting that is conducive to learning and to build capacity and a real enjoyment for nursing. Depends how you define that enjoyment, but somebody that's going to leave the field and go out into their job post-graduation and be what we want to see, a champion for older adults. Somebody that's really going to push that agenda and to advocate for change in care to meet the needs of the older adults. So that's kind of the end target. This really ambitious piece is looking at bringing people together to mentor, to preceptor, to build capacity, and then to build champions that can really help older adults, but also to help the practice of nursing, because with the changes that has come to our scope of practice in long-term care, our scope hasn't shifted. So then when we start to think about that, how do we as registered nurses advocate for our scope? How do we get to practice in long-term care to our scope so that the client outcomes are better, and both ourselves and the client? And what the literature says is when these things come together, the client and the patient and the family and the nurse and all the other staff are actually more satisfied. And I think that would be the highest, to me in my nursing career, if I could provide care with someone that was satisfying and increase their quality of life, I feel like I had succeeded in my role. So thinking about that type of work and building capacity and building champions, we started to talk about a community of practice, a gerontological nurses community of practice through the SRNA. And what would that look like? How would we like to see that structured? Who could we invite to that group? Who would like to participate? How do we open it up and put it out there? So we've built a community at the moment. We're very tentatively we had a meeting a couple of weeks ago, and out of that we decided that this is a really worthwhile experience. Registered nurses from long-term care joined us, the health authority in project leads for aged care within the province, nurses who have retired and have a special interest, community members who have a special interest in older adult care came together, and we talked about what are the possibilities of a practice community and what would that look like. So we've started to pursue that further, and we'll have another meeting in the next, I think it's next week. Time goes so quickly.
It does.
Next week. And what that meeting will be about is talking about building our own practice community. And for me, from working with older adults for the last quite probably my whole nursing career, so nearly 27 years in older adults, is looking at an interprofessional team, not keeping it closed, because older adults are so complex. We need to work outside of our silo. We need to be engaging and having conversations with other team members. So being able to have other team members invited into our practice community. Having nurses, not just in Saskatchewan. I know we work in Saskatchewan, but older adults care and its complexity across the country, there is so much happening that we don't know until somebody publishes an article. It's too late by the time they've published. You know, we're probably creating the same thing in Saskatchewan, but it takes 3 or 4 years to actually produce an article. So if we're talking and having conversations earlier, we will be able to share knowledge. Having a secure place to share that in a community that is respectful and is willing to share, I think is the priority. If we don't start to work together as a team across the province and across the nation, then it gets really hard to advocate for a population where the healthcare dollars seem to always miss. We just don't seem to secure them, and we're not securing staff to stay with older adult care. So the practice community is the next step, and whoever's listening on here, if you are really interested in participating in that webinar, if you can send Terry your email address, and I can send you the link to the webinar for next week, you are more than welcome to join us. And because it would be great to have, you know, if you're engaged in the beginning of it, it's nice to have that sense of ownership. And, you know, we created this, and I can spread the word and really know what it means to belong to a gerontological practice community. But also you are then able to suggest who else might like to join our team. Who would like to come to the community. So at the end of trying to look at the preceptorship, the mentorship, the building the practice community, what we want to do is we want to become a leader. I think Saskatchewan has great capacity to become leaders in the care with older adults. I think there's a lot of chance to have conversations about the great work, particularly in rural communities, that is being done that nobody knows about unless I hear from a relative that says, hey, my mom is in this fantastic nursing home and they're doing this, this, and this. We don't know what's happening out in the rest of the province. So having a place that we could share that expertise and to really promote leadership in registered nurses who work in long-term care, instead of people saying, oh, you work there, I'd never work there. Well, in lots of ways, they probably would never work there because it's hard work. It's relational work. It's working with. You live with people. They don't come and go overnight as acute care. It's a whole different relationship, and it's very demanding. So sometimes I think when people make those comments, it's because, you know what, you wouldn't work here because you're not prepared to do the work that registered nurses do in long-term care. But the long-term care nurse, on the other hand, isn't out there saying we're doing a fantastic job, we're doing all of these types of things, and this is what nurses do. We don't promote ourselves either. So it's both, to me, it's a two-way street. We need to promote, but we need others to recognize the care that we do provide. So out of my work, I guess my research work has presently been with an organization in town called Was Home First. Now it's called Seniors First here in Saskatoon. And what it's looked at is interprofessional teams working with older adults living with complex healthcare needs in the community. And from that, what we have learned from patients is that when they have a voice, it matters. When they're engaged in the care, it makes a difference. When they choose where they receive the care, it also makes a huge amount of difference to the families and to how they grow older. And from taking that knowledge that I've gained is now starting to look at long-term care and trying to really shift long-term care, because from what I hear in the community doing my community research is that we would never want to go there. That is the last place that we want to go to. We won't get the care that we need. We don't get to make the choices that we'd like to make. And the worst thing here in Saskatoon, I'm not sure whereabouts for the rest of you are, is that I don't even get to choose the nursing home I go to. Somebody tells me where I will go to. I do get to choose to make a change and put in a request to change out of the long-term care I've been placed in, but I don't really have a lot of choice. We also know statistically people would rather age in place in their homes, in their personal homes, which I think is significantly important for the registered nurse working in long-term care to understand this is not their first choice. When they're moving into long-term care, sometimes it is unfortunate their only choice for small towns because the services aren't there, or they don't have family to support them, or it's just that they don't see any other possibilities. So long-term care nurses, to me, also then have that responsibility to their communities. Our long-term cares are placed all in communities. We know what's happening in our neighborhoods. We can do a whole lot better job of integrating our long-term care into our communities so that it's an open place. It's not a foreign place. It's not a place that I would not want to go to. It might be a place that the older adult can go to respite and be happy to go to respite so that the caregiver could continue to care for them instead of dreading and saying, no, I won't go. Being able to actually say, you know what, it won't be so bad for a couple of weeks. I'm familiar with the place and people are saying good things. So having that chance for the registered nurse to bridge some gaps between the community and the long-term care home to try and meet some of these expectations of the population that's growing older. For myself, I don't aspire to go to a long-term care home. It would be my last choice. But that's based on I want a place of and making my own choices and having my own decisions and having my own things around me. So how can I expect residents and patients to be given, well, you don't have any more choices anymore. You have to move into this long-term care home. How does registered nurses help to change that story for them so that it isn't, I guess, in lots of ways, so destroying of the person's identity and their sense of self and where they see themselves in community? So I think we have a lot of work to do. I don't think it's going to be very easy. I think starting at the beginning with the registered nursing student, then looking at an interprofessional clinical placement for students. So I am out there looking for preceptors, absolutely. And if you'd like to do that, put your hand up. If you know somebody who would be an excellent preceptor, ask them and tell them to either contact Terry, and Terry, you will be my contact point. But
happy to do that.
Yeah, making those connections and spreading the word out there that we are trying to make a difference here in Saskatchewan, and we are trying to become leaders in caring with older adults that is proactive rather than reactive. The last piece that I'd like to talk to, and I know for registered nurses who work in rural communities, and some of them have nurse practitioners, is looking at how do we shift to the nurse practitioners being welcomed into long-term care rather than being seen as competitive with the medical officers. Because once we can shift the nurse practitioner's role, we will be able to shift the registered nurse's role to that full scope, because we will have the support and the education and the ongoing access to the specialty skills of the nurse practitioner. And sometimes what the long-term care home says, and when I've been talking with the staff, is that we only do the skill once a year. I don't feel comfortable, so we say no. But if you've got somebody and you've got a system that helps support you to do that, even if you only do it once, having that education, that knowledge, and that support person in the nurse practitioner's role will help us to be able to advocate for those skills that people say you lose when you go to long-term care. And I don't think we lose any skills. We learn different skills, which I think are highly important. And some skills, yeah, we give up, but so does acute care nurses. Some of them give up their relational skills, their communication skills, but they're very good at doing IVs. But when the patient leaves the hospital, they don't remember the nurse that gave this excellent IV. They remember the nurse that sat down and talked to them about their day and really asked about how is their care going, how are the decisions they're making. So some ways there's a trade-off, and I think we gravitate to the area that we feel most comfortable. So the long-term care registered nurses that are comfortable, I want to keep them and build their capacity and make them champions of care. the ones that are there, and we know that some graduates just take the job because that's the only job on graduation, and we know there's a pool of them, then if they're going to have to take that job and it's the only one they can have, how are we going to make that a maximum experience so that when they leave, which they will, it's not their first choice, some of them will leave, how are we then going to get them to continue spreading the good news that my experience in long-term care was valuable, I learned all of these things and I can carry them into whatever job I have? Or the nurse that ends up staying in long-term care because nothing else has come up, comes from a rural community, doesn't want to move, lives here in the city, there's no other job openings, and she stays in long-term care, or he stays in long-term care. How do we keep them there satisfied so that they're happy to come to work every day, and we don't suffer from burnout, and we don't suffer from job dissatisfaction in the sense that we're no longer truly a nurse? So on those notes, has anyone got any questions? This is so bizarre, just talking to my screen. And I don't see or hear anybody.
You're doing a great job. So there is someone online who is certified in gerontological nursing, and you've got 2 people that have already sent me emails interested in joining the meeting. So that's a little bit of feedback for you. Also, that there's a comment, I love the idea of a gerontology nursing practice community. How better to share information and learn from each other.
And I really appreciate that, because what we saw in our initial meeting is that our nursing practice community would be a partnership between everyone who joins. So there's an expectation when you join the community that you will be a mentor, that you will share. So if you read an article, we would love you to post the article and, share that information. If you go to a conference, share the information on the community board so that we can see what people are doing and what your skills are. It also means my vision from talking to new graduates or soon to be graduates is that the practice community would support them. I have had students actually turn down long-term care jobs in rural communities because they feel that they're isolated, that they'll be out there all on their own. And I think that really has to change, because we are never on our own as nurses. We have a practice community. We just don't have a connection. So if we can connect that new graduate and support her to go to Spiritwood, to long-term care, knowing that there's mentors right there online. So if she's got a concern, she's joined our community, someone can say, you know what, I'm going to mentor Darla in the first 6 months of her being in that job. She can contact me. She can talk to me. I feel like this is a really good relationship. I'm not looking for a lifetime commitment to the new graduate, but those first 6 months are critical for when they leave. And if we've got an established practice community that can share what nurses say is, oh, it's a burden. It's a burden to orientate new graduates, to precept new graduates. And it is, I totally appreciate it. I have precepted many, and they are tough, and they're exhausting after you've worked 5 days a week with them. But the problem is, I don't feel like I have support elsewhere. So the next time it comes around, I might actually think not to be a preceptor, and I choose not to do that. So I've lost that wonderful preceptor for these students, and we do burn them out because we get preceptorship burden. We use the same person over and over again for the students. But if we have a practice community and you're feeling a little bit overwhelmed, we have someone else to talk to. We also have others on the community that we can say, you know what, next time in my organization, would you mind taking the student? I will mentor you through the process, but could you actually be the preceptor? And I think in lots of ways that will build our confidence, but it also builds our capacity as registered nurses, because it is daunting when students ask you these difficult questions and you're not really sure. And you sometimes feel it's not great to be a preceptor because you're having to think constantly. Your day is just this drain of knowledge. So if you have that community to go back to and share your experiences, and also then to me, unload the burden and to move it forward. Other questions?
Not so far. I just put another little message out there just reminding people that they can add those questions in, or comments about what they're hearing from you. this is really exciting. And so there is kind of two parts to this, where you would become a gerontological nursing professional practice group with the SRNA. And one of the tools that you could use to make those connections is this new online community of practice that we're developing from the SRNA. So this is kind of a cutting edge piece. We're hoping to launch next week with our first few pilot groups. And so then the gerontological nursing group would get introduced.
We'll be signing up for that.
Yeah. Yeah.
Because I think for gerontological nurses, because it's so spread out, I think it's really important. And it's not just long-term care where registered nurses work with older adults, is that we can spread it out through the online practice community. And it's a safe environment for people, a safe platform. I was telling Terry previously that we had looked at a Facebook site, and I have it already, graphic design and everything is done, and I just haven't hit the launch button, and now we're going to shift it into this online practice community, because it does give us a safe place to communicate, and also to have a sense that we're being cared for ourselves, because we really need to have that safe place to come to. I see a comment over here. Do you think we need RNs more so in long-term care or home care, or both? Is it partially a funding issue as well? And that's a really interesting conversation, because I thought in Canada that registered nurses weren't being hired into long-term care because of the financial reasons. And there is an element of that. Licensed practical nurses are cheaper. And so some organizations have chosen to go for licensed practical nurses rather than registered nurses. However, an interesting conversation with a project lead is that the communities post first for a registered nurse and no one applies. So then they get LPNs only. They have a duty of care to their community to provide a service. And so hence they employ the licensed practical nurse. It is not their first choice. It is often the only choice that they've got. And it comes down to that duty of care. They can't close the nursing home because they didn't get a registered nurse. They must provide the service. So it is both. Where do we need registered nurses? Home care, long-term care, right across the board. Registered nurses need to be more looking at particularly case coordination and that advocacy and leadership role, and helping people navigate, particularly older adults, helping them to navigate the healthcare system. And registered nurses have that knowledge. And what we do with that knowledge, unfortunately, is often we just put it aside. We don't take those opportunities, or the organization isn't structured that we can take those opportunities. So how do we advocate for that role, that we can actually do what we're taught to do and to practice full scope? So I hope that answered your question, Amy. It's a very good question, and we need to advocate for registered nurses in both areas, particularly in older adults. They are so complex. Their care cannot be delegated to only licensed practical nurses and special care aides. We know that their complexity then ends them up in emergency departments for poor diagnoses, poor interventions, poor care, even care that it goes unrecognized that they need something done. So we cannot do without them. The next question is, Crystal, as a capacity building exercise, I would love to see 221 practicum groups sent to rural sites. Me too, part of their time in acute care facility. And this is something I've definitely started to explore with Lana, and I can't pronounce Lana's last name, Anyway,
Christi, I think, yeah.
Christi. Anyway, I have started to talk to Lana about this. To me is the ideal placement for a 221 and also 450, the final practicum in the registered nursing program, is that if we have this opportunity to work across the whole facility, then they don't just see that they're going to long-term care. And that's what they see first. Students go, oh, long-term care. I've drawn the worst place. Whereas they see a rural hospital and they see acute and long-term care, a lot of the time students say to me, that is perfect. when I go home, I want to work in the rural long-term care hospital. It's great to get that opportunity to do it as a student. The students that I have the privilege to support to do this, it has been hugely successful, and they have really enjoyed the experience and have left with a very different understanding of what it means to care with older adults. So yes, and if you would love to join us in our research to push this, do join us, Crystal.
Yes. I think giving every nursing student the experience of going into rural centers is so important in Saskatchewan, because so many of our clients, even if you never have any intention of working in a rural hospital or rural area, a lot of the clients that you see in the city are going to come from the rural areas. So to understand where people are coming from and to understand the resources that are available to them are so important.
And I think for older adults that becomes very crucial, because a lot of them transition to an urban center because of their healthcare needs at a very late age. So they're not making transition choices at 55, 45. They're making transition choices at 75, when they're no longer able, or what they see themselves as being no longer able to remain in their homes, and they turn around and there's no choice in their small rural community. There is no home care that can come every day and provide them assistance. There isn't the GP at the clinic every day of the week. He comes once a week or 3 times a week. He's not reliable. The next service is 50 kilometers away and I've lost my driver's license. There is no way I can commute to that next community to receive my care. So I end up moving to an urban center. And for some of them, it's just a move to Prince Albert. We're not talking Saskatoon or Regina. I mean, some of those urban centers, the next one up from them might be Prince Albert, might be North Battleford. A very different culture, a very different way of living, and oftentimes moving into kind of close living. They're not living on their farms or in rural communities where, you know, we see Mrs. Jones blind go up every morning and we know that she's okay. When it doesn't go up, we phone her. They're not living in those communities here in the city. They don't even know their neighbors, because oftentimes, if they're not well, all their time is spent at medical appointments. They're not going to the senior center down the street. If they could do those types of things, they'd still be living in their rural communities. They're really here for intensive healthcare needs. So their circle of abilities of meeting and greeting other people is very small. So they are often very isolated in the urban centers, and also very lost and unsure of how to navigate a system. The rural hospital, they could just walk in and someone would say, "Hi, Mrs. Jones, how are you today? Please take a seat." They walk into emergency here at IUH, nobody knows their name. And they have to navigate to find the triage lady they have no idea what that whole process is. So even learning how to do urban healthcare compared to doing rural healthcare, if that nursing student or that first year nursing graduate can have that experience, when they come back into the cities and encounter older adults who have transitioned, it is so much help to have some understanding of where did they come from.
Absolutely.
Mm-hmm.
Yeah.
Anything else out there?
I'm not seeing anything else. Just one other, so Crystal had also commented that she's taught that course a couple of times, 221, and that she would have loved to have been able to take the long-term care students, take them to long-term care for a few shifts.
Yes,
So
and
that's
having
a great
that flexibility. Mm-hmm.
Yeah.
And Crystal, my last clinical placement, I have taught clinic for long-term care, well, for the 10 years of my teaching until I moved to the university here. So the last 2 times that I taught long-term care placement in that first year at SAS Polytech is that we actually went to an assisted living, one of those residential retirement communities, instead of long-term care. And what I found there was the students actually learned about older adults, because the older adults in these residential communities, some, yes, were living with dementia, some were living with impaired ADLs and IADLs, but they were able to have important conversations about those hard to ask topics, about intimacy, about making choices in their care, about living with their husband and being the caregiver and being 88 years old, and what does that mean? What does it mean to move into a residential facility designed specifically for older adults? And so I found that it really, after the placement, they thought they had been cheated because their friends at long-term care were doing all of this technical stuff. And I said, so what's the technical stuff that you're doing? Well, they get to bath people. I said, well, why aren't you bathing? Your residents have a bathroom in their own rooms. You can bath them every single day. Really? Well, you have to ask. In long-term care, they're on a bath list. You just pick it up and you go bath them. Here you have to negotiate and learn those skills. When they're doing blood glucose, there's a blood glucose list here. Go forth and do that. Why don't you ask? You know, and ask the person, would you mind? Can I just practice taking your glucose? So I think in lots of ways, the student goes into long-term care wanting to practice their skills. Those hands-on things. They want to bath someone. They want to do a glucose. They want to do the insulin. They want to take a blood pressure. And those skills start to really overtake what it means to actually work with someone. We become so skill focused, we forget about the person. And we just see them as a task. And after the long-term care, the 12 weeks that we spent there, at the end of it, the learning that came out of it was enormous. They were talking about end-of-life care, and these are first-year students. They were talking about how the person's ulcer really interfered with their socialization. They were talking about food choices and how they were struggling when they moved into this residential facility, struggling that the menu was set every day, and where's our choice, and how do we get a choice? And it was just fascinating. So I think that being able to take them is so important.
So just one more comment there, and if those students.
Crystal, I'd love to meet you. You sound just the person. You are so right, Crystal. I just finished teaching an older adult class in third year. It's called, oh God, the title's terrible. It's called Exploring Chronicity and Aging. Terrible title. When I saw that, I thought, oh, so all older people get chronic diseases? Is that what it's about? Anyway, so we did, I really changed the focus of the course, and we really talked about person-centered care, patient engagement, decision-making, care coordination, and chronic diseases, of course, came into the conversations because it's what the person is living with, what their experience is. But having those person skills, having a conversation and learning, and I say to the students, these are difficult questions to ask, you know, with older adults. As a married couple, I had one couple say to me a couple of weeks ago, they're being married 67 years, and they're 90 and 87, and she says, I don't like him going dancing on Friday nights because he's dancing with other women and I feel jealous. And I'm like, wow, how do you get into that conversation at this age after all these years of marriage? and at this age, you're concerned about other women finding him attractive. And I thought, isn't that interesting? Because how often do we even have those conversations with older adults? And how much courage does it take to have that conversation? And so we talked about these situations in the classroom quite a lot, and the students did find it very difficult. They didn't really even know how to begin the conversation because we spend so much time in education teaching them skills. It's the whole focus. A large percentage of the curricula is about skills. And those pieces, their mental health component, their communication class, the older adult class, students don't see that as being the really important. To me, that's the building block of our career, but they see the skills as being the building block of their careers. If they can put an IV in exceptionally well, they're a good nurse. And I think we really need to start to look at that. What is the message that we're giving nursing students when they go out into practice? if they can't communicate, how are they a good nurse?
Yeah, those people skills are so important. And like the comment says, if they can learn those person skills early on, they'll apply and carry them throughout every other area of their nursing career.
And they so will. And that's how we see champions in long-term, in older adult care, is that if you can be a champion older adult care, which to me are one of the most complex clients that we ever work with, is that it's going to roll out into no matter what population you work with, because you will be paying attention to all those small nuances, their hearing, their vision, their thinking, making sure that they're engaged. So even when you work with pediatrics, you will begin to ask the pediatric patient what it is that they would like, rather than asking their parent what is it that they'd like.
Mm-hmm.
And it does shift and carry over hugely into all areas of nursing. But I also think that that older adult piece and becoming champions is that older adults are turning up in every area of nursing. We have parents in pediatrics that are 55, 60-year-olds with newborn babies. Either they've adopted or they've had their babies late and the child is 5, 6 years old and the father is 60 or the mother is, 50, 55. We're starting to see this population shift. So no matter where you work, older adults are turning up in large numbers. And so having that skill, it transfers across absolutely every field of nursing.
Yeah. Very good. So like I said, I've already seen a couple of notifications come through that there have been a couple of people that have put their name forward to join your meeting next week. So that's exciting. Awesome. So I'll send those emails on to you. Yeah. While we're just waiting for, this is going to probably be our last call for questions and comments. I'd just like to remind everyone that the SRNA annual meeting and conference is coming up May 1st, 2nd, and 3rd. And we've got a lot of great activities planned. We've got a pre-conference this year on May 1st, which is about leadership and leading in complex times, which might feed really nicely into the work in gerontology and, would be ideal. One of the great things about that conference is that if you come with someone else that you're working with, and you can put your name in to actually attend the 4-day Dorothy Wiley CNA residency leadership course that will be held next spring. So that is, it's huge. It's valued at over $8,000, just that tuition fee. So that's great. We're having a member links night the evening of May 1st, our education day on May 2nd. We've got both Mike Villeneuve and Barb Shellian coming from CNA. So lots of great speakers, so much time to engage and really talk about some of these important issues. And then on May 3rd is our annual meeting, and we've got several bylaws that are going to be voted on. We have a webinar coming up in 2 weeks that will go through what those bylaws are and why they're being presented for change. So we need people to register and book their rooms if you're from out of town, and we hope a lot of you can join us. So I don't see any other questions. So thank you very much, Rosalind, for spending your lunch hour in between teaching to share this great movement. And really, you're showing what a leader registered nurses can be in our province by, just taking this one thing and bringing in all the different partners that can help improve caring with older adults.
Yes. So. And thank you very much, Terry, for the invitation. It's been an exciting journey the last few months, and I think this is one more way of actually putting our message out there and making connections to nurses across the province, and encouraging nurses working with older adults to really come together and to get a united voice. And if we can get that practice community and start to really use it as a place of support, mentorship, and to build champions, I think we're well on our way to making change. So thank you very much for the opportunity.
Wonderful. Thank you so much. And thank you everyone for attending. And we'll have a wonderful, wonderful afternoon.